All right, let's dive into the pharmacology of cholesterol and lipoprotein metabolism. This is an absolutely essential topic if you want to understand cardiovascular health, things like why high cholesterol is such a big deal, and more importantly, how the drugs we use to treat it actually get the job done inside our bodies. So here's our roadmap. We're going to start with the real basics. What are lipids, lipoproteins, and cholesterol? Then we'll follow their journey through the body in the transport pathway. After that, we'll get straight into the drugs, starting with the heavy hitters, the statins, before we cover the other important medications out there. We'll wrap up by comparing how well they all work, their safety profiles, and then take a little peek into the future of cholesterol treatment. Okay, first things first, let's get the fundamentals down. Because really, to understand how any of these drugs work, you have to get a handle on the body's own system for moving fats around. Think about it. Our blood is mostly water, and fats like cholesterol and triglycerides, well, they don't dissolve in water. So the body had to come up with a clever solution to this problem. And that solution is the lipoprotein. You can picture it as a kind of biological taxi service or a transport shuttle. It's a special particle that's designed to do one thing really well: package up those water-insoluble fats, those lipids, and carry them safely through the bloodstream to wherever they need to go in the body. This image shows you the really elegant structure of a lipoprotein. Right in the middle, you have a hydrophobic or water-repelling core. This is where the main cargo, the triglycerides and cholesterol esters, is kept safe and dry. And wrapped around that is a hydrophilic or water-loving coat. It's made of phospholipids, some free cholesterol, and special proteins. This outer shell is what lets the whole particle travel smoothly through the watery environment of our blood. Now let's zoom in on those special proteins on the surface. They're called apoproteins, or apolipoproteins, and they are absolutely critical. They really have two main jobs. First, they act as ligands. You can think of a ligand as a key that's designed to fit into a specific lock on a cell, which is the receptor. A great example is ApoB100. It's the key that lets LDL particles bind to LDL receptors on the liver. Their second job is to be cofactors, which means they help enzymes do their work. For instance, ApoC2 is essential for turning on an enzyme called lipoprotein lipase, which is responsible for breaking down triglycerides. So you should know that not all lipoproteins are created equal. They're actually sorted into 5 major classes based on their size, their density, and what they're made of. At the very top, you have chylomicrons. These are the biggest and least dense particles because they're almost 90% triglycerides, and their job is to transport the fat we get from our diet. Next up is VLDL, or very low-density lipoprotein. This one carries triglycerides that are made by our own liver. Now, as VLDL travels around and loses those triglycerides, it transforms first into IDL and then into LDL, low-density lipoprotein. LDL is very rich in cholesterol, which is why you've probably heard it called bad cholesterol. And finally, we have HDL, or high-density lipoprotein. It's the smallest and densest of the bunch, and it's known as good cholesterol because its job is to go around and collect excess cholesterol, bringing it back to the liver. We spend so much time talking about lowering cholesterol, but it's important to remember that it is absolutely vital for life. It's a key structural piece of all our cell membranes, it helps transport triglycerides, and it's the starting material, the precursor, for essential molecules like steroid hormones, the bile acids we need for digestion, and even vitamin D. Our body makes most of it in the liver through this really complex 37-step process. And the speed of that entire process is controlled by one single crucial enzyme, HMG-CoA reductase. Now remember that name, HMG-CoA reductase, because it is the main target for our most important cholesterol-lowering drug. Okay, so we've met the key players, the different lipoproteins and cholesterol itself. So let's move on to our next section and see how all of this fits together into the full lipid transport pathway. We're going to follow the complete journey of fats as they move through the body. This diagram gives us a fantastic bird's-eye view of the whole system, which really has 2 main routes. Let's start on the left with the exogenous pathway. This one kicks off when you eat a meal with fat in it. That dietary fat gets packaged into chylomicrons right in your intestine. From there, they enter the blood, where an enzyme called lipoprotein lipase, or LPL, starts breaking down their triglycerides, releasing fatty acids for your tissues to use as energy or for storage. What's left over, these are called chylomicron remnants, gets cleared away by the liver. Now, the second route is the endogenous pathway. This is what your body does on its own. The liver packages its own triglycerides and cholesterol into VLDL particles. And just like the chylomicrons, VLDL circulates, gets its triglycerides removed by LPL, and transforms into IDL, and then finally into that cholesterol-packed LDL. LDL's job is to deliver cholesterol out to peripheral tissues, but the liver also takes a lot of it back up. And all the while, you've got HDL doing what's called reverse cholesterol transport. It's like a scavenger, picking up extra cholesterol from the body and bringing it back to the liver for disposal. So why does all of this matter for your health? Well, these are the numbers that doctors look at on a blood test. And there's a reason these measurements are taken after a 10-hour fast. It's so we can get an accurate snapshot of that endogenous pathway, what your liver is up to, without any interference from a recent meal. High levels of these lipoproteins that can contribute to plaque, especially LDL, are a huge risk factor for heart disease. And as you can see from this chart, an LDL level over 160 is considered high, which is exactly why the main goal of almost any therapy is to get that number down. And that brings us perfectly to the drugs. So let's start with the most important and most widely used class of lipid-lowering agents out there, the statins. They're our first-line defense, and they work by going right to the source and inhibiting cholesterol synthesis itself. I'm sure you've probably heard of some of these medications. Simvastatin, lovastatin, pravastatin, atorvastatin. They are all part of a powerful class of drugs known officially as HMG-CoA reductase inhibitors, but pretty much everyone just calls them statins. So how in the world do they work? Well, it's a really clever chain reaction. First, statins competitively block that HMG-CoA reductase enzyme in the liver, the very enzyme we said controls the whole process. This directly slows down the liver's ability to make its own cholesterol. So what happens next? The liver cell senses this drop in its internal cholesterol levels, and in response, it activates these special proteins called steroid regulatory element binding proteins, or SREBPs for short. Third, these SREBPs march into the cell's nucleus and switch on the gene that makes LDL receptors. And this leads to the fourth and most important step: more LDL receptors pop up on the surface of the liver. With way more receptors available, the liver can now act like a vacuum, pulling much more LDL cholesterol out of the bloodstream. And as a nice little bonus, this whole process also leads to the liver producing less VLDL to begin with. And the results are pretty impressive. We're talking a 25 to 60% drop in LDL, plus a modest decrease in triglycerides, and a small bump up in the good HDL cholesterol. Now, let's get into some key details. Some statins, like simvastatin, lovastatin, and pravastatin, are short-acting. They're usually given at night to line up with the body's natural peak in cholesterol production. Others, like atorvastatin and rosuvastatin, are long-acting and generally more potent. Here's a cool fact. Lovastatin was originally isolated from a fungus called Aspergillus terreus, and simvastatin is actually a semi-synthetic version of it. Simvastatin is also what we call a prodrug. That means you take it in an inactive form, a lactone, and then your body hydrolyzes it to make it active. But here's the most crucial point for safety: metabolism. Many common statins, like simvastatin, lovastatin, and atorvastatin, are broken down by an enzyme called CYP3A4. Now, if a patient takes another drug that blocks this enzyme, say certain macrolide antibiotics or the immunosuppressant cyclosporin, the statin levels can build up to dangerous levels, seriously increasing the risk of side effects. It's also important to know they can interact with the blood thinner warfarin, potentially making it more potent. Now, while statins are definitely the foundation of treatment, they aren't the only tool in the box. So let's move on to some of the other key lipid-lowering drugs. These give doctors a more multi-pronged approach for managing complex lipid disorders. Let's compare two totally different strategies. On the left here, we have the fibrates, drugs like gemfibrozil and fenofibrate. They work by activating a special receptor inside the cell nucleus called PPAR-alpha. When you switch this on, it turns on genes that boost the activity of lipoprotein lipase, that enzyme that's so great at breaking down triglycerides. Now on the right, we have niacin, which is also vitamin B3. It works in a completely different location. It acts in our adipose tissue, our fat cells, where it inhibits an enzyme called hormone-sensitive lipase. This action reduces the release of free fatty acids from fat stores. So if the liver has fewer fatty acids to work with, it simply can't make as many triglycerides and can't produce as much VLDL. Next up, let's look at two other classes of drugs that both do their work in the intestine, but they go about it in very different ways. First, you've got the bile acid sequestrants, like cholestyramine and cholestyramine. These drugs aren't even absorbed into the body. They stay in the gut, where they literally bind to bile acids and prevent them from being reabsorbed. This forces the liver to say, hey, I need to make more bile acids, and to do that, it has to use up its internal cholesterol stores. As a result, the liver puts out more LDL receptors to grab more cholesterol from the blood. The second path is taken by ezetimibe. This drug is much more direct. It specifically blocks a transport protein called NPC1L1 that sits on the surface of intestinal cells. And by doing so, it physically stops dietary cholesterol from ever being absorbed in the first place. Okay, let's get into the nitty-gritty for each of these. The bile acid sequestrants can lower LDL by about 20%, but a big drawback is that they can sometimes make triglyceride levels go up. They can also interfere with the absorption of other drugs and fat-soluble vitamins. Ezetimibe, on the other hand, doesn't mess with fat-soluble vitamin absorption, and it's a fantastic add-on therapy. In fact, when you combine it with a statin, you can get an extra 20% reduction in LDL. Niacin is very effective at cutting VLDL and LDL, and it's one of the best drugs we have for raising good HDL cholesterol. But its use is often limited by side effects, like intense facial flushing, which taking an aspirin beforehand can help with, as well as GI problems and the potential for liver issues. And finally, fish oil, or omega-3s. These are excellent for lowering high triglycerides because they work by inhibiting VLDL synthesis in the liver. They also have other nice benefits, like reducing platelet function and having anti-inflammatory effects. Phew. Okay, we have covered a lot of different drugs and a lot of different mechanisms. So let's transition now to a really crucial section where we're going to compare their effectiveness side by side and, just as importantly, talk about the most significant safety concerns. This table does a great job of summarizing the different strengths of each drug class. If you look at that LDL reduction column, you can see immediately why statins are the first choice. They give you a powerful 40 to 50% reduction. But now, if you glance over at the triglyceride reduction column, the fibrates are the clear winners, with a 40% drop. Niacin is a pretty good all-arounder, and you can see it's the most effective drug at raising HDL. And notice that the resins, those bile acid sequestrants, can actually increase triglycerides. That's a key point. Ezetimibe gives you a solid 19% LDL reduction on its own, which is why it's such a useful drug to add on. All right, let's talk safety. The most well-known side effect of both statins and fibrates is myopathy, which is muscle toxicity. About 10% of patients might experience symptoms like dose-related muscle pain, tenderness, or weakness. The risk is definitely higher for certain people, like those over 70 or people with kidney problems, hereditary muscle disorders, who drink excess alcohol, or have hypothyroidism or diabetes. But here is the most critical warning of all. The risk of severe myopathy is significantly, and I mean significantly increased when the fibrate gemfibrozil is combined with a statin. This combination should be avoided.
The other major concern is liver damage or hepatotoxicity. Now, the good news is that this is rare, it's dose-related, and it usually happens early on in therapy. Because of this risk, there's a very clear monitoring protocol in place. Doctors will measure liver enzymes, called aminotransferases, at baseline before the patient even starts the drug. Then they'll check again after 1 to 2 months, and then about every 6 to 12 months after that. And the best news is that if liver function is affected, it almost always goes right back to normal after the drug is stopped.
You know, statins have absolutely revolutionized cardiovascular medicine. There's no question about it. But even when a patient is on the best possible statin therapy, a significant amount of risk can still remain. And that reality has pushed researchers to look for new targets. So let's move to our final section and explore what's on the next frontier in lipid management. This final slide shows some of the really exciting new pathways that are being targeted. So first up, and probably the most well-known, are the PCSK9 inhibitors. PCSK9 is a protein that your body makes that actually causes LDL receptors to be destroyed. So monoclonal antibodies like evolocumab work by blocking PCSK9, which allows those LDL receptors to be recycled over and over, dramatically increasing LDL clearance by 40 to 70%. Another approach is inclisiran, which is a small interfering RNA that literally tells the liver to stop making the PCSK9 protein in the first place. Then you have bempedoic acid. It inhibits cholesterol synthesis one step earlier than statins do by targeting an enzyme called ATP citrate lyase. And what's really cool is that it's a prodrug that's only activated in the liver, which might reduce the risk of those muscle side effects. Next are the ANGPTL3 inhibitors, like evinacumab. ANGPTL3 is a protein that inhibits lipoprotein lipase, so if you block it, you help clear triglycerides more effectively. And finally, you have ApoB inhibitors, like miphomersin. This is an antisense oligonucleotide that targets the messenger RNA for ApoB, preventing the very assembly of the LDL particles in the liver. These powerful new tools are really changing the whole landscape of treatment, which leaves us with a key question. How will this next wave of therapies reshape the future of preventing cardiovascular disease?